Very good afternoon to all. So next 10 minutes, I will be talking on RET gene alterations. So we all have witnessed how the lung cancer care has there is an evolution of lung cancer care over a few last 2 decades. So from the histology subtypes, now it is an era of all molecular subtypes, and it is a need of the hour that we molecularly characterize each and every tumor. And why is that so? Because targeted therapy has become the standard of care for NSCLC. So whenever you get a lung biopsy, after you establish that there is a malignancy, you first see whether it is a lung origin versus a metastatic. Once it is a lung origin, you will see whether it is a neuroendocrine versus a non-small cell carcinoma. After non-small cell carcinoma, you will histologically subtype adeno, squamous or adenosquamous, whatever it is. The need being in adeno, at least you should do EGFR UL cross PD-L1. And cases with squamous where you cannot entirely rule out adeno, you will still have to go for EGFR UL cross in a particular scenario, and PD-L1 yes in all NSC on squamous. If these markers are negative, then you can extend the panel and include other genes, and RET is one of those genes. So what are the guideline recommendations? If you see, RET gene is included as per NCCN, CAP and ASCO guidelines as not a single gene testing, but as a part of the expanded gene panel. So RET gene is located on the 10 chromosome long arm, and it encodes a receptor tyrosine kinase. Like any other tyrosine kinase, it also has an extracellular, transmembrane and intracellular tyrosine kinase domain. So when it comes to RET alterations, it is usually mutations or fusions. And when it is fusion, it is restricted to the tyrosine kinase, that is the intracellular domain spanning the exons 12 to 18. And the cysteine-rich extracellular domain is mostly pertinent when it comes to mutations. So with RET alterations, it is seen across varied solid tumors, but most commonly seen in thyroid carcinomas. And in NSCLC, we see that the RET fusions are common, and it is seen in approximately 1 to 2% of NSCLC. So what happens with RET fusion is that the tyrosine kinase domain will come juxtaposition, that is the 3' end of RET gene will come next to a 5' end of any other gene, which will lead to a fusion gene protein, and which further activates the downstream cell signaling pathways, leading to uninhibited cellular growth. So as with any other fusion proteins in lung, RET also has multiple fusion proteins, the most common being the KIF5B, which is the kinesin family gene. Other common genes are coiled domain, that is CCD6. So clinicopathologically, if we see, the RET gene alterations fusions are common in young non-smoker females, and there is some data to suggest that the solid variant of adenocarcinoma has more propensity for this RET gene, but it is too preliminary to quote that. Timelines. So after in 2012, after the first RET fusion was reported in lung cancer, over the next few years, there were many trials on the TKIs, and subsequently in 2020, selpercatinib got the accelerated approval by FDA after the data showing the overall response rate of 64% and the response duration of lasting for 6 months or longer. So subsequently, it got the FDA approval. So coming to biomarker testing platform, there is always a question like which platform to be preferred for which biomarker genes. So which methodology? It all depends on where you want to test the biomarker, whether it is a DNA level, RNA level, or a protein level. So coming to the first platform, that is IHC. So for a pathologist, it is very easy, speed, cost effective, and interpretation is very easy. In lung, if we see, ULK is a very successful story, which is now IHC is a predictive biomarker. And with ROS, we see it is mostly as a screening test. So let's see what is with the RET gene. So some studies have used IHC as a screening test, absolutely not the gold standard. There are also some monoclonal antibodies available for RET IHC. But what are the current impediments is that there is a very high rate of false positive and false negative, as high as 40%. This can be because of some low expression of RET fusion protein and lack of specific antibodies. So in current scenario, the use of IHC is discouraged. So let's see what is the next, that is the FISH. So with any biomarker, FISH is considered as a gold standard, especially for the gene rearrangement. It is a very sensitive and specific. And most importantly, in lung, when we have very scanty tumor tissue, it is very pertinent. You just need one slide of 2 to 3 microns. So it is very, when you have no other tissue left, this is one platform that you should explore definitely. But it needs technical expertise and complex rearrangements can be missed. So when it comes to fish, it is very important that you should have some lucid understanding about what is the partner gene loci. So if we see RET gene, the most common, that is the KIF5B gene, is seen in 70 to 90%, followed by CCDC, which is seen in 10 to 25. And if you look at the partner gene loci, it is very close proximity to the RET gene. Now, this is very important when you see what is the fish probe design for RET gene. So if you see, it is the same, near about same loci. So in fish, what do you see? When you use a break apart probe, you see how separate the signals are. As you can see in the figure, the red and green are very wide apart. But this doesn't happen if the partner genes are very much in close proximity, which is an issue with the RET gene. So this is one issue. Another thing, is there any prognostic or predictive relevance to the RET fusion partners? In ALK, we know that there is some prognostic evidence for the ALK fusion variants, type 3, which is exon 6 and exon 20, having little poor prognosis. ROS, we don't have much data, but in RET, it is seen that CCD6 fusion protein has a better survival as compared to the most common fusion partner. Also, the chances of CNS mets is more common with KIF5B. And there is also some data that is postulated that these fusion partners may affect the sensitivity of the RET TKIs. That means there is some data to suggest that there is importance to know the fusion partners. So when it comes to fish, so the close proximity can lead to false negative result. And also you use break apart, you cannot determine the fusion partners. So it is also not an optimal platform to be used for RET. Next, coming to reverse transcriptase PCR. So it is highly sensitive and specific. But when it comes to multiple fusion partner in diagnostic setting, you cannot devise different primers and do so much multiplexing. And even if you do, there is always a chance that you might miss on the fusion partners, leading to false negative. Then comes the last platform, that is the next generation sequencing. So we say that next generation sequencing is very highly sensitive, specific, and it is known to detect all the known possible fusion. However, it is resource intensive and there can be a little turnaround time issue as high as 3 to 4 weeks. But when it comes to fusion analysis, few points to be kept in mind for NGS analysis. So first and foremost, for fusion analysis, when you do NGS, you should know what is the level of analysis, whether you are using DNA or you are using a RNA. What is your targeted gene? Is it a very limited panel or you are using an extended panel? And also the library preparation method, whether it is a hybrid capture versus a amplicon sequencing. So DNA is very stable. You will know other gene alterations, like you can detect SNPs, you can detect CNVs. Also, you can detect fusion only if your library preparation is covering the exact intronic region. If RET, we see the fusion, most commonly the breakpoint is the intronic region 11. But sometimes it might happen in intronic 7 or 10. So if your library, the coverage is not extending into this intronic, you will miss this gene rearrangement. So anyways, for all fusion, we say that RNA based is more important, because irrespective of whatever is your breakpoint in whichever intronic region, you will adequately capture the fusion partners. Is this time? Oh, okay. Okay. So that is why, second thing, hybrid capture, you can include large gene panels, whereas when you use the amplicon based, you should know which are the left side partners and the right side partners. So what does that mean? There is also a possibility that you will miss on some of the novel fusion partners. So it is not that every time if you see a NGS negative, it means that it is negative. You should have adequate knowledge about what panel is used and what genes are used and what is the coverage. So with this, if I want to say that when it comes to RET, targeted DNA NGS will be more comprehensive, as it will have a unique advantage of exploring novel partners as well as simultaneously exploring the somatic mutations with low allele variant frequency. As in RET, it is not just fusion, it is also mutations which is seen across various solid tumors. However, as I said, complex fusion will be a limitation, and RNA NGS adds value to the accurate detection. So this is just to summarize that IHC and FISH will be having some sensitivity and specificity, and RNA-based NGS is best for the fusion. So when it comes to testing methodology, potential local implementation is okay with IHC and FISH, but in the current scenario, not recommended in testing. The NGS is the platform. So to strategize, DNA NGS can be used as a preliminary screening if there is an adequate tissue. If tissue is an issue, very low tumor cell content, then FISH can be explored. And any unusual results with DNA NGS or FISH, RNA NGS is the orthogonal validation technique and the final answer. Thank you. I would like to thank you all for patient hearing.
Thank you, Dr. Trupti, for giving that wonderful presentation about RET fusion interpretation. Now I would like to invite Dr. Bhavesh Poladia. He is a consultant medical oncologist at Thangam Medical Cancer Center at Namakkal, Tamil Nadu.